anyway, we are switching to modern endovascular decisions for SFA intervention. And we also invited a modern speaker, Gilles. You are the first speaker?
Yes, it's only one same presentation.
Ah, voilà.
And
yeah, it's all the same.
Yeah.
Fantastic. It's a
You have
teamwork.
Exactly.
Very good. We are looking forward. Please.
Thank you. Merci.
Vas-y, toi, comme tu parles en premier.
Okay, so good morning, everybody. Thank you for the invitation. Thank you for Boston Scientific. We were supposed to be 3, but finally we're 2. So Caroline has the bad job today because she has to defend the pro stent and the con stent. So
I'm a bit schizophrenic, but my boss is going to tell you it's usual.
You will do exactly as Koen is always making. So one pros and cons is the same.
So we'll discuss about modern endovascular decision through a recorded case. So I will show you to begin this case about a male patient, age 70, who were referred for recurrent left intermittent claudication. He already had a AAA endograft, so it prevents any contralateral approach, and a left popliteal bypass 14 years before. So he had in the CT scan a stage disease on the SFA involving the first third and the proximal anastomosis of the bypass. So as I mentioned just before, the access strategy was inevitably from antegrade approach due to the endograft, and so we went antegradely, and this is the angiogram. You can see a very severe stenosis on the third part of the SFA. They were highly calcified on the CT scan, and they are eccentric, nodular, especially on the proximal anastomosis of the graft. Not too bad runoff with 3 patent vessels, only mild stenosis of the proximal ATA, and a good runoff to the foot. So our strategy was to go directly with a 7-trench sheath, because we never know, and then using a Corbacat and to cross the different and to access the proximal SFA. So this was just to have an overview of the case, and now we'll discuss the different strategies, and we move further into our strategy and our decision.
Thank you, Gilles. So Celine's point of view was, well, I want to stent this lesion. I think it's not going to respond well to POBA. So basically, the first thing you want to do if you want to stent is, I think, cross intraluminally, because as Gilles say, you never know. Depending on what you're going to want to use as vessel prep strategy, you've got all the options if you're intraluminal. And the lesion was calcified, so sometimes it's a bit difficult. So it might take some time. We'll see with Gilles if it was easy or not for him. Then what she wanted to do was aggressive PTA, and she's really pro high pressure balloons, because the idea is to gain as much lumen as you can. So you want to reach reference vessel diameter to be able to expand your stent properly and to avoid residual stenosis. So if you know from the start that you want to stent, dissection, I suppose, is not really a concern anymore, because you're going to scaffold it with your stent. Although I still think that you kind of want to know where you want to stop your stent. You don't want this dissection to go too far down the bypass, for instance, or down the distal below the knee lesions. And another question is going to be, which stent do you want to use? You're going to want something with high radial force, I suppose, especially if you just press with a balloon, because you want it to open up. And then you're going to want it to kind of resist to fractures, because it's the fempop area. We know it moves a bit. And you're also going to want to have the longest primary patency as you can get. So with all of that in mind,
can we
go ahead.
Go back, please? This one slide back, Caroline?
Yeah.
No, back.
Sorry,
yeah.
I'm trying to.
Yeah. So can we ask the audience? Does it fit in the concept? Yeah.
It can. It can, of course.
Okay, so the questions of Caroline or her Swiss friend. So what do you think? You've seen the lesion, so you agree with the strategy, very aggressive pre-dilatation.
We can play the angio again.
With high pressure balloons or non-compliant balloons, and then actually afterwards stenting. And if yes, which stent? So somebody wants to comment on this? Is a high pressure balloon the correct way of prepping this kind of lesion? Question mark? There is some doubt in the audience. I don't see really
Here we are.
enthusiasm.
Good to see you. I'm Dr. Kim from South Korea. In my country, we have several types of the atherectomy devices. In this case, I prefer the no stent strategy with the atherectomy, and the collie balloon is better than the stent, I think.
So that's going to be my talk afterwards. So I'm just going to finish Celine's talk, and then we'll see my point of view, because I kind of agree with you.
Good. Good. You may work in South Korea.
Okay, so one other comment?
Just as you suggest, if I'm looking for a special balloon, probably why not IVL? We are in a calcified lesion, circumferential, a channel to go through. With a non-stent strategy, probably I will go for that if it's a special balloon.
Yes.
Just one observation, real quick. So I think that at the end of the day, you want to prep the vessel. The question is on the table, what are you going to use? You're going to use a non-compliant balloon, you're going to use a focal force balloon, you're going to use atherectomy, you're going to use lithotripsy. It looks like it's calcified, so it sways you one direction. In your second angiogram, if you can show it one more time, there's one thing to notice. Go to the second angiogram.
Could you play left popliteal?
Yeah, right here. So when it's going slow, you see at the end of the picture at the top of the lesion, it looks like nodular calcium, these circular round balls. Let me just point this out. When you use atherectomy, very, very cognizant of that look, because what happens is a lot of these little round balls, these calcium, will come dislodged and go downstream. So if I was going to use atherectomy here, orbital in particular, rotational, those would be the two. I'd be very conscientious to put a filter down, because you're going to throw stuff distally. And these are hard to get out. So just take that into consideration. So lithotripsy or a non-compliant balloon is what I would use.
Perfect.
We'll see later.
We're going to go through all of that.
Go on.
So in terms of just choosing your stent, if you look at self-expanding nitinol stents, just bare stents, at 12 months, you see that the longer the lesion, the lower the primary patency rate that you'll get. So once you've kind of increased your lesion length, it's going to become more difficult to get sustainable results. Now, if you look at drug-eluting stents, like a polymer-based Eluvia stent, you see that even if you're going with a long lesion, the result seems to be sustainable, even with a lesion of more than 200 millimeters. This was with a full lesion coverage, so not spot stenting, full lesion coverage with the DES. And there was this big meta-analysis using all of those results from different types of stents, Eluvia, silver PTX, covered stents, and bare metal stents. And you see that with even with long lesions, you had an increased primary patency rate at 12 months with the Eluvia stent. And this was also showed with just the long lesions, more than 15 centimeter length. Still, you had an advantage with the Eluvia DES at 12 months compared to the other types of stents. Yeah, basically that's a resume of what I just told you. There was this meta-analysis and there were some subgroup analysis, and you see that the delta kind of increases with the length in terms of primary patency. So the other question is, we say DES is probably better than a BMS, but is it going to be silver, PTX, or Eluvia? Well, at 12 months, we've got data showing in the Imperial study that Eluvia does better than silver, PTX. The meta-analysis also showed the same thing, that there was kind of a difference when the lesion was getting longer. Silver, PTX was performing worse. and Illuvia remained steady. And in the real DES study, I know that there was no significant difference, but at 12 months, you still kind of had this gap between the two, even if it wasn't as big as the one that we saw in the Imperial study. The question is, as we all said, it's a calcified lesion, so the concern is going to be, do we think that the DES is actually going to work in calcium? And there were some data on that as well. So in the Imperial study, there was a subgroup analysis with moderate to severe calcifications. And at 12 months, it showed that you had a sustainable primary patency, 92.5. And it was also shown in the Munster registry with PAX 3 and 4 lesions in almost 70% of patients, a 94% rate of primary patency. So probably calcium is not as much of a concern, at least at 1 year, even with a DES. I think another question is, do we think there's a class effect between BMS and interwoven stent, meaning the supra stent? And do we think supra will do better with calcium once we prep the lesion with a high-pressure balloon? Well, there's this Japanese study, the Eldorado study. So it's not a randomized control trial. It's a propensity match score. But still, no significant difference between the two. So I suppose supra is going to do the same or a bit less, but no significant difference again, versus DES with the Illuvia stent. So I think if we see the picture with I'm a pro-stenting girl, in a complex eccentric lesion, you're likely to have a high dissection rate, recoil, if you just use POBA as prep, even with a high-pressure balloon. So you're likely to need a stent. And if you're going to need a stent, maybe you're going to want to use paclitaxel on it because you want to have a sustainable primary patency. The thing you're going to have to think about is to not extend your stent too much compared to what you were thinking about treating first, and to really know where your landing zone accuracy is going to be. What do you think, Gilles? Would you have done a full metal jacket for this patient?
I didn't really think about this option because I was fearing malapposition with the stents. Of course, you need a proper vessel prep, and you need, I think, from my point of view, debulk because we have an eccentric lesion. So I don't believe that IVL would be sufficient to avoid any stenting. So you keep the risk of needing a stent with the IVL. I was not very confident with this option, and I really didn't want to implement stent here because it's a severe patient with a AAA graft, another graft on the other side. So it perhaps come later, is only 70, but I wanted to keep options.
I kind of agree with you, and that's what I was going to tell you. I can work in Korea because I would have done a DCB strategy, I think, for this patient. Because we agree we need to prep the vessel, so I'm going to talk to you about IVL after that. And we kind of agree that we might need a drug-eluting strategy, but do we really think that with a drug-coated balloon we would have done worse than with a DES? So that's kind of the question. But I agree that if we just prep with POBA, we are going to expose ourselves to residual stenosis, probably over 30% in those eccentric bulk lesions. And we're probably going to set ourselves for failure because we know that DCB after residual stenosis is kind of a predictor of failure. Now, we also know that there is a high risk of dissection if we use a high-pressure balloon of POBA. And there are data showing that with a high-grade dissection, you're actually going to lose more than 10% rates of primary patency and freedom from TLR. So I think we want to avoid that dissection at all costs. And that's also what this expert panel said when they did this disform classification, saying that if you've got a dissection with a spiral dissection or multiple linear dissections or maybe a flow-limiting dissection or residual stenosis, it was more than 50%, you're going to want to stent these lesions, basically. So then the question is, if we have that kind of problems, how much stenting are we going to put? And the thing is, if we look at the results, the longer the lesion, the higher the rate of rescue stenting. And if the lesions are more than 20 centimeters, it's 1 out of 2 patients who will actually need rescue stenting. And if we look at rescue stenting, you would have thought that by adding a stent, you would improve primary patency, but actually, the primary patency still goes down. So maybe in a long lesion, DCB plus rescue stenting is not doing that well. And we also know that DCB plus BMS, we thought it could be as good as DES. That's what the compare trial was saying. But it was a shorter lesion, less than 50 centimeter. But if you look at longer lesions, the longer it gets, the higher the gap. And in longer lesions, DCB plus BMS doesn't really perform as well as a DES from the start. And not even thinking about the cost. You know, depending on the systems of reimbursement, it might also be a problem, especially if you want to prep your vessel properly. Because one of my thinking was IVL, actually. I love IVL. And I was thinking, well, maybe it could be an option here, because I want to crack this calcium. And with IVL, what's great is that I think compared to atherectomy, like you said, you get a risk of embolization, stuff like that. Well, IVL is really safe. So worst case scenario, it might not work, but it will not harm the patient. And I think that's also something that you want to think about, especially if it's just claudication. But there are a few problems, I agree, with IVL at the moment. There's lack of plaque removal. Like Gilles said, the plaque is going to remain in place. We're just going to crack the calcium. We don't really control depth, at least with the IVL balloons that we've got now. So if it's a very bulky plaque, we might not go all the way through the plaque. And then you're going to pick a diameter and length. You've got a number of cycles. And if it's not enough, let's face it, it's already really costly. So you might not want to use a second IVL balloon or not want to use another device to debulk. And there's profile constraints as well, because it's a 014 guide wire that you're going to use, and maybe you might not even cross with the profile of the IVL balloon. That's also something that we can worry about. So maybe Gilles is right. Maybe here, with the high dissection recall risk, even if I use IVL, it might not work. Maybe a DCB is not going to perform that well if I just use that. What do you think?
So the answer is just after. So to summarize the case, we have 3 very short lesions, almost between 1 and 2 centimeters. We have access to stents minimally 2 centimeter lengths for the superior, for example, and 4 centimeters for the eluvia. So I really don't want to put 2 or 3 spot stents. And if I put a longer one, I have concern about apposition. And we know that malapposition is increase the risk of instant restenosis. So we finally decided to treat this patient with atherectomy, rotational atherectomy, because we want to gain lumen and we want to modify compliance wall and to remove some plaque. So the crossing was not really an issue. I first started with the support guide wire that we usually use with Jetstream. So I started with the Spartacore, which is of course not a CTO or crossing guide wire. So I move on for CT1. It was Command ES, the new one, Command ES 014 ST, that allowed me to cross the distal lesion that was almost occluded, and then we exchange again for the Spartacore, which is the guide wire we used for as a support. And our vessel prep strategy there was to use the Jetstream. France is a poor country, so Jetstream is not reimbursed, and of course a filter neither. So I quite never use filter with Jetstream, but of course I have major concern about distal embolization, as everybody. I'm a Jetstream user for 10 years now, and we have a very low rate of distal embolization, thanks to a very cautious use of Jetstream and some tips and tricks to avoid this distal embolization. So this is the role of atherectomy that I've just summarized before. And then we'll move on to this. So our treatment algorithm is to cross each lesion after another. That means I first treat the first and second lesions, and I keep the distal one as a natural filter. So I will reduce the risk of distal embolization before treating the last lesion. So it's my filter. So I first treat the first lesion, a first pass with blades down, of course, and then Rex mode just below the more distal lesion to aspire the little dust or debris that could come downstream. And then what I do to avoid distal embolization in such calcified lesion is that I activate the blades open and I pull back the catheter. So we will debulk the plaque with the proximal part of the blades, which are very close to the hole, aspiration hole. So we're in the good way to remove the plaque. And in this eccentric plaque, when you push down the catheter against this eccentric plaque, your catheter will be pushed against the LC-wall from the other side. So when you pull back your catheter, you will stretch the guide wire and you will better debulk the convex part of the plaque. So that's what I use. And in this case, for example, these are 3 very short lesions, but the activation time of Jetstream is around 10 to 12 minutes. So it's very, very long. It's very, very, very slow. And if you're cautious like this, there aren't any or very low risk of distal embolization. So you can hear the acoustic feedback of the Jetstream, and you know after several passes that you do not debulk anymore. So this is the first pass with blades down. Then this is the Rex mode. We pull back the catheter with the Rex mode, and then we engage with the blades open. This is the last one, and you see I pull back the catheter with the blades open. Then we're in the LC vessel, so it moves inside. So this is one way to reduce the risk of distal embolization. And then after having prepared the 2 first lesions, I go down for the last one. And in this one, I'll be much more cautious because, as you mentioned before, the risk is to detach some large nodular calcification downstream and create distal embolization. So this is the result after the first segment. You can see on the left side, after the first pass with the blades down, and then the second one with the blades open, you can nicely see the lumen gain here. And for the distal segment as well, it's not as evident as the proximal lesion, but of course it's only a vessel prep technique, and then after you have to treat the vessel. So this is the flow, and we have a nice flow after the different passes with blades open, especially on the right side, with a much better flow at the end. One advice is to inject into the saline bag of Jetstream some nitrates and isoprenaline to prevent any spasm distally, and we inject always almost 1 milligram per kilo of heparin for this patient. And as a post-op protocol is to introduce DAPT for almost 3 months, and then SAPT plus rivaroxaban 2.5 milligram 2 per day. And then finally, the treatment. After the vessel preparation, we used different Ranger DCB, 7 millimeter of diameter and 6 centimeter on the proximal part, and a 940 for the distal part, just at the level of the proximal anastomosis. Almost all the balloons were inflated for 3 minutes. This is the final angiogram. We can see a nicely open vessel with a good flow inside, no significant residual stenosis. It's not perfect, of course, at the level of the proximal anastomosis, but we didn't put any stents. We have no distal embolization, quite a slow flow, which is often observed, but it's a transient phenomenon. And the patient had a pulse distally and absolutely no ischemic issue at the end. So this was our strategy. Of course, I think there's other ways to treat these kind of patients, but we really wanted to gain lumen, avoid dissection, and avoid stent implantation in this case.
Thank you.
Good, perfect. Thank you. So like you said, Jill, there are many ways to roam to treat this case, and I was already a little bit confused with what Caroline was saying, and I thought first we're going to end up with a full metal jacket of Illuvias, but then you try to avoid. So actually, in quite challenging lesions like this, what is actually the problem with stenting? You mentioned a few times, yeah, I'm afraid that I will miss some wall apposition, what is of course extremely important, and cardiologists know this better than vascular surgeons, how important it is. But is this the only reason you want to avoid stenting with this fantastic one-year data that Caroline showed, or are there other reasons to avoid stenting here? Because I have the impression, also the audience, that today everybody is a little bit afraid of stenting. I'm a stenter. I love scaffolding.
I love too. I have to confess.
But I'm feeling more and more like a sinner.
No,
the laws are leaving nothing behind. Please.
No, not at all. But in this particular case, as we had really, really short lesions and eccentric lesions, I had real concern about the vessel wall position of the stents, because
correct.
If I use atherectomy to debulk, to remove some plaque, to gain lumen, why not trying just DCB? Why implant a scaffold if it's not needed? So in cases where you don't have access to atherectomy, you need a proper vessel prep using non-compliant balloon or IVL. But in this case, it won't be enough. So you will need scaffolding if you don't remove plaque. So in this case, okay, you go for stenting. And of course, DES, I think it's a good option in this case. But only if you can nicely and properly prepare the vessel. But in this case, if you go for atherectomy, you have the best vessel prep as possible. So just go for DCB.
Comments on this topic in the audience?
Yeah.
More scaffold
I've
believers?
got one, because this is nonsense what you say, Gilles, because if you say the main risk of stenting, this is the malapposition of the stents, okay? This is what you mentioned. Mm-hmm. And the risk of instant restenosis or stent fractures or stent thrombosis. But considering the fact that you scaffold, this means you retrieve the majority of calcium, thus you decrease the risk of malapposition.
Sure.
This is a nonsense of, is it necessary to scaffold, to primary scaffold, or to secondary scaffold? We do not have the answer yet, and in terms of long-term patency, and but it remains here a floating zone, and we do not have the answer.
So I think in short lesions, it's kind of safe to think that DCB is going to be enough. And if you can avoid implanting a stent, why not? Why would you want to have metal that might, at some point, have a fracture risk, or avoid any other bypass landing zone? And why not just use DCB? And if it doesn't work properly, then you still can stent afterwards.
Yeah, of course. This, again, once again, this is a nonsense. What you mentioned, Caroline, this is the landing zone for distal or proximal bypasses. We never implant bypass where we retrieve calcium. I mean, that was a
But if you have a long dissection below this bulky plaque, then you might end up in one that would be suitable for a bypass. And we know that ISR is also very difficult to treat. So if we can avoid having a metal and ISR, then it's going to be easier if you want to treat your patient in a second procedure.
But this is an extra option for the next time if he comes back, because this patient will probably come back. He has a severe disease, so we just keep an option open.
But Caroline, now I need to challenge you a little bit.
Go ahead.
Yes, because now you are mentioning, we're going to do a good DCB, and then if there is a dissection, whatever, then we're going to do a bailout with a stent, I assume, with a bare metal stent.
No.
But on the other side, you say, yeah, but a combination of BMS and DCB is not as good as a primary stenting with a nice Illuvia. So what do I need to do now? Do I need to stent immediately primary stenting with Illuvia, or do I need to do a DCB first and then bailout stenting where needed? I'm confused.
You need to prep your vessel correctly. So once you've prepped
everything
your
is depending
vessel,
on the vessel preparation.
you do your angio. If you've got a good vessel prep result, then I think it's safe to use DCB.
Correct.
If you see that you've got residual stenosis, dissection, don't go for DCB plus bare metal stent. Rightly go to DES right away.
Very clear.
Actually, there aren't any contraindication using DCB plus DES.
And then
Yes.
we move to Gunnar Tepe.
So
Back to
exactly,
double shot.
exactly.
The circle is around.
Yes.
No contraindication. So why not deploying an Eluvia after DCB failure or dissection or residual stenosis after?
Yeah.
Aren't any contraindication.
Comments? Audience is very quiet. Or they all agree, or they are sleeping.
Or they are confused.
Yes. Okay, good.
We
More
move-
comments? I think we can finalize the discussion here. Thank you very much. It was a great
you.
presentation.
Thank you very much.
you.
Thank you so much, Andy.